Dr. Sruthi was my senior in MBBS, was my senior for some time in MD when I joined Trivandrum Medical College for 1 month. And so I've been knowing her for a long time. She's associate professor at the Department of Neurology in Sri Chitra Tirunal. As a Chitra in the Neuromuscular and Multiple Sclerosis Division. She's a supervisor of postdoctoral fellowship in neuromuscular disorders. She has received lots of fellowships, Young Neurologist Award. She's a rank holder and gold medalist, I think, from 10th standard onwards. I don't think she missed any gold medal from 10th standard onwards to 10, 12, pre-degree to medical college. Any gold medal she has missed. She has a lot of publications, and she's in the Kerala State Technical Committee of Multiple Sclerosis and a lot of research projects in MS and in genetic neuromuscular disorders. Over to you, Dr. Sruthi.
Thank you very much, Vishnu. A very good morning to everyone. I'll start sharing my slides. So I hope everyone can see my slides. At the beginning, I would like to thank Dr. Vishnu and IAN for giving me an opportunity to be part of this wonderful program. So after a very detailed presentation, that has almost simplified my task a lot. We will now be seeing an approach to mononeuropathies and multiple mononeuropathies. So here I will start by introducing a few clinical pointers to focal diagnosis of focal peripheral neuropathies. Then we will see in detail some of the common upper limb and lower limb neuropathies. Just briefly go through some of the uncommon ones as well. And finally, we'll have a few slides on multiple mononeuropathies. So the broad classification of peripheral neuropathies based on their distribution is the very common or the classical one, which is a distal symmetric polyneuropathy. The asymmetric forms are mononeuropathy, which affects only a single nerve, or multiple mononeuropathy, where there is more than one nerve that is affected in non-contiguous areas as a rule, but it can also be contiguous areas in certain conditions. But although we tend to think of neuropathies as the prototype of neuropathies being a symmetric polyneuropathy, it should be known that the mononeuropathies are the most common subtype of peripheral neuropathy. So in any patient we see, we think our analysis in basically three plans. One is, where is the localization? Where in the neuroaxis does the disease come from? And once we know where it comes from, we need to know what is the cause of the disease, that's etiology. And finally, when we determine the etiology, we can go ahead with the management part of it, either symptomatic or specific management. So in peripheral neuropathies, what we usually advocate is to go by a pattern recognition approach. So of the examination part, the 6 major questions which we need to ask is it a symmetrical syndrome or an asymmetrical syndrome? Is it only distal, only proximal, or both, or one dominant over the other? Is it sensory, motor, or both? Is it an autonomic involvement? And peculiarly, we need to know also if there is upper motor neuron findings and midline findings as like tongue weakness or neck weakness or truncal weakness. So of these, a peripheral nerve involvement mostly would focus around the first 3 questions. So mononeuropathies are asymmetrical and affect only a single limb. Distal is more common than proximal, although the distribution will depend upon which nerve is affected. And a combination of sensory and motor are more common than motor and sensory, but that again depends on which nerve and which part of the nerve. We call it mononeuropathy multiplex or multiple mononeuropathies when it is still asymmetrical, but there is involvement of more than one nerve, with or without involvement of the cranial nerves. Now, when the presentation is asymmetrical, there are a lot of possible localizations. It can be either an anterior horn cell involvement, a root involvement, or parts of it, just the ventral root or the dorsal root. It can be the sensory ganglia, the plexus, individual peripheral nerve, or the peripheral nerve branch. Now that we have heard in detail about the nerve roots and plexus, we will now focus on how to diagnose if it is an individual peripheral nerve or a branch involvement. Now, if you need a single thing to make a diagnosis, it is a knowledge of the anatomy as well as the root values of the more important nerves of the upper limbs and lower limbs. So you would approach it based on motor examination, a sensory examination, the reflex, as well as a specific test which you need for mononeuropathies is to do a provocative test to see whether that particular nerve can be stretched and we can reproduce the symptoms which the patient talked in the sensory domain. The sensory impairment, there are 3 zones of sensory impairment. You have an autonomous zone, which is a very small area which is exclusively supplied by one particular nerve. It also has a maximal zone, which is the entire area which is supplied by the peripheral nerve, but there is an overlap of innervation by other peripheral nerves as well, and that overlapping area is known as the intermediate zone. In order to make a diagnosis of a mononeuropathy, the most useful one is the autonomous zone. So the ulnar nerve, you can see that the autonomous zone is the dorsal as well as the palmar aspect of the little finger. For median nerve, the autonomous zones are the distal to distal interphalangeal joints for the second and the third fingers, particularly in the palmar aspect. For radial nerve, it is anatomical snuff box, which is the autonomous zone, which is the web space between the first and second fingers on the dorsal aspect. For common peroneal nerve, a vertical strip which is in front of the ankle is considered the autonomic zone. And for tibial nerve, most of the sole of the foot except the medialmost part it's an autonomous zone for it. The things about sensory involvement is that one, sensory can be episodic involvement, and it can be normal on examination when you are seeing the patient. Paresthesias are not very useful to understand the distribution of the nerve involvement because they often extend beyond the distribution of the nerve. When we are looking at the different modalities, we find that the area of light touch loss is larger than pinprick loss in form because that has more of autonomic by a single nerve and less of overlap. And if you want to look for very, very minimal involvement of sensory involvement, the test to do would be a 2-point discrimination. So when you are assessing the improvement of nerve recovery, it is important to know that from no sensation, the initial the initial sign to come is a deep cutaneous pain, followed by superficial pain and touch, and finally the 2-point discrimination. And this is important to know because the patients continue to have paresthesias even when there is worsening of the neuropathy as well as during the period of recovery. So it is good to know to what extent and what sensations have recovered while you are doing follow-up examinations. When you're examining for the motor involvement, predominantly you're looking for weakness which is confined to muscles supplied by a single nerve. That is when you call it a mononeuropathy. So you have to remember that a single action may be done by multiple muscles, and if you have a stronger muscle, it may mask the activity of a weaker muscle. For example, supination is done by both biceps and supinator. But if biceps is strong, a weakness of supinator may be masked. So you may have to do the test by disadvantaging one muscle over the other. And secondly, weakness of one muscle may cause apparent weakness of another muscle and may overlap with multiple nerve territories. And a very peculiar example is that of a radial nerve producing wrist drop, and that can lead on to a pseudo-ulnar weakness because of a mechanical disadvantage. Especially in the post-trauma setup, you have to see whether a joint, muscle or facial disease is also causing what looks like weakness when it is actually not primarily a nerve disease. So the points which can be used to differentiate that is that passive movements will also be restricted or will be painful in case of a joint, muscle or facial disease. And secondly, sensory as well as reflex involvement would speak against it being just a musculoskeletal problem. And finally, I will not be dealing on this later, but you have to also know that anomalous innervations are not uncommon. And this will interfere with your not just clinical examination, but also with your nerve conduction studies. An example is you have a cross connection of median and ulnar both at forearm and can also occur at the level of the wrist, at the level of the palm. How it will affect is that suppose you get predominantly everything which looks like an ulnar neuropathy, but on examination you also find that there is mild weakness of APB and opponents. This you have to work out whether it can be an anomalous innervation by extending your nerve conduction study a bit and looking at what happens when you stimulate that particular ulnar nerve. Is there a movement of the abductor pollicis brevis? That is what you have to see and decide whether it is an anomalous innervation or not. There are other methods in MCS also which we can use. Of course, the other symptoms and signs you will look for are atrophy, fasciculations, and hypertonia, all indicating an element type of involvement. The deep reflexes were already discussed by Dr. Madhu. So we mostly rely upon biceps, supinator, triceps, knee jerk, and ankle jerks, which have very specific root values, and the nerve distribution is for biceps musculocutaneous. For supinator and triceps, it's a radial nerve. For knee jerk, it is a femoral nerve, and ankle jerk is tibial nerve. We can also use a finger flexion reflex, which is supplied by median and ulnar nerves, and adductor reflex, which is supplied by the obturator nerve, but it is less useful for an element manifestation than for a human manifestation. So the presence of these are considered to be more useful, though the absence does not particularly mean anything. And autonomic changes in case of a mononeuropathy would be focused along the distribution of that nerve. So you can look for all the manifestations you will look for in a polyneuropathy also. That is, the skin will become dry, scaly, and thin. Reduced sweating would be seen. The edema of skin is common, especially in certain specific neuropathies. Nails may be brittle, and there is propensity for ulcers would be seen. So you call it a mononeuropathy. I will repeat that when all deficits are confined to a single nerve distribution. But this need not be the complete nerve involvement. So to what extent that nerve is affected will depend upon the site of involvement of the nerve. So if you have a median nerve at the wrist, all the branches which were supplied above the level of the wrist would be spared. So the completeness of involvement will depend upon whether which level of lesion it is. And secondly, a very important phenomenon that you should know is a fascicular preference. So you may have a median neuropathy at the level of elbow, but you may have weakness of only the muscles of the hand. And that can occur just because there is a propensity for the fascicles of those particular muscles to be affected. We may be able to make out the exact site by using either Tinel sign or certain provocative manuals, which we will see individually when we go on. The etiology of mononeuropathies, they are common in most situations. There are specific etiologies required in certain situations, but other than that, you have to consider all of these when you are in a given situation. The most common ones are trauma and compression or entrapment neuropathies. So the compression can be an acute compression, like you have a person who has undergone a surgery and has been put in a certain particular position for a long time, or you put a bandage or a cast, and that can produce acute compression. The compression may also be extrinsic, like a tumor or a hematoma. The acute traumas, whether it is laceration, stretch, or crush injuries, can also produce a mononeuropathy, which usually is concomitant with the onset of at the time of trauma. Vascular focal ischemia of the nerve, as well as hemorrhage within or outside the nerve, can also produce mononeuropathies. Infections, particularly leprosy, Lyme's disease, HIV, HBsAg, can produce mononeuropathies. Immune-mediated diseases include mostly vasculitis, but also you have variants of CIDP, sarcoidosis, which can cause mononeuropathies. In addition, you have to know that injections and radiation exposure can sometimes present as mononeuropathies. Now, when you are talking about compression-related neuropathies, you can have a subtype which is entrapment neuropathy, and compression neuropathy is due to many other causes. So if an entrapment neuropathy refers to something which has been going on for a very long time in a region where there is a propensity for the nerve to become compressed. On the other hand, acute compression is usually an abrupt onset, and they present more with weakness and less with pain and sensory. And entrapment neuropathies, the pain and sensory would be the dominant features, while weakness would be a later feature. So that certain features would predispose a person to develop, or a particular nerve to develop entrapment. And this will include the regions where the nerve becomes superficial, particularly the ulnar nerve at the level of the elbow. The regions where the nerve passes through fibrous or osseous structures or between the heads of nerves, as for example the carpal tunnel syndrome or the fibrotendinous arcade at the level of the elbow for ulnar nerve. When the patient has certain extrinsic factors like a job or a recreational activity which can predispose to an entrapment. For example, a person who has to type a lot or a person who is a professional cyclist may be more prone to have entrapment neuropathies at the level of the wrist. And polyneuropathies may confuse you in the sense that diabetic polyneuropathy, hypothyroid neuropathy, all these can predispose to development of coexistent mononeuropathy. So you may end up thinking that this is an asymmetric neuropathy and not a polyneuropathy. So we'll go on to certain individual nerves and see how to localize and how to reach the diagnosis of mononeuropathy. So I'll go slow with the first two, but we may have to go faster later on. So as I told, the minimum thing you should know is the course of the nerve, but particularly having to know where in the course of the nerve it is prone to compression. And secondly, where are the specific branches being given, both motor and sensory. So median nerve, as was discussed by Dr. Madhu, is a mixed nerve which arises from two cords. That is the lateral and the lateral cord which contains a C6 to C7 fibers, and the medial root which contains a C8 to T1 fibers, and they join together at the axilla to form the median nerve. So when it descends down, it goes along with the brachial artery, and in the arm there are no branches at all. At the level of the elbow, after it gives off a few branches and then enters the protocteres muscle. It goes along almost the middle of the forearm and then enters the wrist through the carpal tunnel, that is deep to the flexor retinaculum, and beyond that it branches into its terminal branches. So the branches which we need to know is that at the arm there is no branch at all. In the forearm, just at the entry into the protocteres muscle or before that, it gives off branches to protocteres, flexor carpi radialis, palmaris longus, and flexor disthalis superficialis. So we are talking about pronation, the flexion of the wrist, and the proximal interphalangeal joint flexion. And anterolaterous nerve is given within or immediately distal in the within the protocteres muscle, and it supplies mainly three muscles. It's a pure motor nerve. It supplies flexor pollicis longus, flexor digitorum profundus to index and middle fingers, and pronator quadratus. So this is not dealing with flexion of wrist. There is flexion of the thumb, first and the second finger, and the pronation. And about 5 to 6 centimeters above the wrist, it gives off the palmar cutaneous branch. It enters the hand through the carpal tunnel and then immediately gives off the recurrent thenar motor branch which supplies the hypothenar muscles, which is the abductor pollicis, opponens pollicis, and superficial head of flexor pollicis, as well as the first and second lumbrical muscles. The digital sensory branches are given to innervate the lateral 3.5 fingers of the hand. So specifically, we have to note here that the palm is supplied by the palmar cutaneous branch, which is given above the level of the carpal tunnel, and the distal branch supply only the fingers. The sensory territory of the median nerve is the lateral 3.5 regions, where we earlier saw the autonomous region. The region which is shaded as a cross-hatching is the region which is supplied by the palmar branch, and this will not be affected by the carpal tunnel syndrome. We'll just briefly look at one case. This is a 20-year-old male who presented with a numbness and weakness of left hand, which started acutely. He woke up with paresthesia and numbness of the hand, including the palmar aspect and tips of the lateral 3 fingers. He told that he was sleeping on his hand, and when he woke up, he had this numbness as well as a difficulty with pinching and gripping with his left hand. Now, this is more consistent with an acute neuropathy, which can be an acute compressive neuropathy or an acute neuropathy due to some other etiology like a vasculitis. But on examining the patient, here we are trying to see whether we can implicate the lesion to a single nerve and at which segment of the nerve. So here, he had mild thenar wasting and weakness of all the thenar muscles. There was weakness of both the lateral FTP as well as the flexor digitorum superficialis. And this suggests that it is confined to the median distribution. The motor is confined to median distribution. but it is not at the level of the wrist. It has to be at least at the level of above the elbow. And the pain and touch were also impaired along the 3.5 fingers, but also including the palm, again suggesting that it is not at the level of the wrist, it is proximal to it. So now we'll just see how we can localize. So if the disease at the level of axilla, arm and the cubital fossa, you'll have weakness of pronation as well as wrist flexion, particularly radial wrist flexion. The thenar muscles as well as the finger flexion of the lateral 2 fingers will be lost, and loss of sensation of the whole of the median territory of the palm as well as the fingers. When it is anterior interosseous nerve, there is weakness of the finger flexors as well as the pronator quadratus, but the sensory will be normal. In the lower forearm, depending upon the exact site, you may or may not have sparing of the palmar sensory, but the thenar muscles alone would be the weak muscles. And in the wrist, palmar sensation is spared. So there are a few hand signs for median neuropathy. One is the simian hand or the 8th thumb, which is seen in this patient's left hand. You can see that there is wasting of the thenar muscles, making the radial abduction posture of the hand is gone, and it has come in parallel with the rest of the palm. And this is the 8th thumb deformity. And another sign which you have is a pointing index, which is due to loss of flexion. That is a loss of weakness of the flexor distal superficialis and profundus. And when the patient tries to make a fist, there is inability to flex the DIP and PIP of the index finger, and a less deformity of the middle finger. This is same as a benediction hand. Although it is sometimes confused with ulnar, the benediction hand should be used in for a median neuropathy. So we come to the sites where median nerve can be entrapped. The most common one is the carpal tunnel. This most commonly affects women and dominant hands more than non-dominant hands. Extremely common disease to the extent that 1 in 10% can be affected over a lifetime, and in more than half it is likely to be a bilateral disease, even though the symptoms may be unilateral. You should remember that carpal tunnel syndrome is a constellation of symptoms. It is not a nerve conduction finding. So it is only if the patient has the pain, paresthesia, and the sensory symptoms which are confined to median distribution, along with the clinical evidence or the nerve conduction or ultrasound evidence of a median neuropathy at the wrist, should you call it as a carpal tunnel syndrome. So the carpal tunnel is a very tight fibrous canal, which is through which you have 9 tendons along with the median nerve, and covered by the flexor retinaculum and the transverse carpal ligament. Now, how do you differentiate it from the other causes which can cause a similar symptomatology, that is radiculopathy as well as plexopathies can also cause similar sensory symptoms of the hand. So one is the nocturnal worsening as well as the precipitation of the symptoms by gripping or holding objects like driving or by holding a newspaper is highly suggestive of a carpal tunnel syndrome. The patients have more symptoms at night, and a typical sign is a flick sign, which you can see here, where the person wakes up in the morning and flicks his or her hand repeatedly to improve the paresthesias. The sensory symptoms and signs are dominant over the motor ones. Motor comes usually late. In the hand, which is illustrated here, you can see there is wasting of the abductor pollicis brevis with sparing of the adductor pollicis. So you can confirm or your diagnosis of carpal tunnel can be substantiated by using provocative tests. Most commonly used one is phalanx test, where you keep the hand in a flex posture facing downwards for a period of about 1 minute, and you see whether you can reproduce the tingling and paresthesias which occur in carpal tunnel syndrome. A point to note here is that rather than keeping the elbows flexed, it is ideal to keep the elbows extended, because you don't want to confuse this with the coexistent ulnar entrapment neuropathy. So phalanx test, to keep it for 1 minute and see whether it can be reproduced. A reverse phalanx test can be done by hyperextending the wrist and seeing whether in 1 minute you can reproduce the symptoms. The other two tests which can be used is Durkin's and Turton's test, which is by compressing the nerve over the wrist and for about 30 seconds and seeing whether the symptoms can be reproduced. By combining both the compression as well as flexion of wrist, there is increased sensitivity. So overall, these provocative tests are not very specific. You can have a similar symptoms which are produced by myofascial syndromes as well. So they are not very useful as a specific test. In fact, the specificity is somewhere around 15 to 20%. The sensitivity is far higher, 50 to 60%, but not sufficient to be useful for a clinical diagnosis. Another sign which you can use is a Tinel sign. So this can be done using your fingertips or using a pointed percussion hammer. You can very firm tapping over the nerve at the site of compression or along the distribution of the nerve. If it reproduces the tingling paresthesias, it is considered as Tinel's positive. This is not specific for median. It can be used for any other entrapment neuropathy. And it is particularly useful in a post-traumatic or a post-surgical patient when you want to follow up the patient. So you can see that the site of Tinel sign should keep on progressing. That indicates that the nerve is regenerating. The most common etiology is idiopathic, or rather it is due to repeated compression due to the maneuvers of the hand. But you would be looking for a coexistent diabetes mellitus or hypothyroidism or acromegaly, inflammatory disorders of the joint like tenosynovitis or arthritis can produce carpal tunnel syndrome. Pregnancy is another condition which commonly predisposes to carpal tunnel syndrome. So if a patient has a job or an activity which has repeated hand movements, there is an increased risk. We should also be watching out for red flags, which are evidence of a non-dominant involvement is very markedly more over the dominant hand. And if the motor is dominant over the sensory, it is good to get a more detailed evaluation and rule out that it is not an idiopathic carpal tunnel syndrome. Now at the forearm, you can have median neuropathies either just due to compression alone, which I will tell later, but it can more commonly it is due to trauma or mastication, or as part of a generalized disease such as multifocal motor neuropathy or mononeuritis multiplex. So there are multiple entrapment sites along the nerve, along the distribution of the median nerve, but the two important ones are at the level of just proximal to the elbow joint, that is at the level of Sruthers ligament, and in the forearm, in the pronator teres. So this ligament of Sruthers is not a normal variant, it is an abnormal structure which is seen in about 1% of normal population. You have a spur of bone which is located about 3 to 5 centimeter proximal to in the humerus from the elbow joint, and a ligament of Sruthers connects this spur to the medial epicondyle, and the median nerve tends to pass underneath it. So you can produce a compression of the median nerve at that level. The more common one is a pronator syndrome or pronator teres syndrome. Here, this occurs when the nerve passes through the two heads of pronator teres. And the typical feature is a pain which radiates down from the proximal forearm. And when you pronate the hand against resistance, the patient will have reproduction of the same pain. That is by the activity of the muscle. Depending upon where the anterior androgenous nerve arises with respect to the level at which the nerve is compressed, you may or may not have weakness of muscles affected by that nerve, but you tend to have weakness of the palmar sensory nerve. Involvement of the palmar sensory nerve and the hand muscles. The anterior androgenous nerve syndrome, otherwise known as the Killow-Nevin syndrome, is a very specific neuropathy which is a pure motor neuropathy. As I mentioned earlier, there is weakness of flexor pollicis longus and flexor digitorum profundus 1 and 2, which leads to this sign which is known as the OK sign or the pin sign. When you try to make an O with the forefinger and the thumb, in a person who has anterior androgenous nerve weakness, the O is not formed. So here, idiopathic situation is common in most situations, but it can also be produced by repeated exercise producing hypertrophy of muscle and compression onto the nerve. CME infection can sometimes produce bilateral anterior androgenous syndrome. A very important thing we should know is that it can be from first day of neuralgic amyotrophy. So if you have anterior androgenous neuropathy which was preceded by a pain, and it is possible that it is a partial manifestation of neuralgic amyotrophy. It can also be a manifestation of MMCV. Recently, a study, or maybe in 6 years back, a study was conducted to see where exactly in the median nerve was a lesion for anterior introsseous neuropathy using MR neurography studies. And surprisingly, it was seen that it is not at the level of forearm that the lesion is there. Of the 20 patients, in all 20 patients, a lesion was found about 14 centimeter proximal to the humeroradial joint at the elbow. And this is what we just mentioned about fascicular preference. The nerve, although it is arising at the level of the forearm, in most cases of anterior introsseous neuropathy, it is actually the median nerve which is affected at the level of the mid-arm, and that is particularly because of the positioning of the fascicle of which is destined for anterior introsseous nerve posteriorly and more prone to affection. So for the first case, we decided that it is likely that the patient has an involvement which is proximal to the branch to the flexor digitorum superficialis, and hence probably proximal to the elbow. This was reflected in a nerve conduction study which showed a conduction block between the conduction at the level between elbow and axilla. And we did a MR neurography which showed that there was a neuroma at the lower third of the arm on the median nerve, and it was taken up for a surgery. So second nerve is the ulnar nerve, which is a branch of the medial cord of the brachial plexus, which mostly contains C8 and T1 fibers. In the arm, it is medial to the brachial artery and enters the elbow between the medial epicondyle and olecranon. This is a very important site where the nerve is prone to compression. As soon as it leaves that groove, it enters a fibrous arcade, which is formed by the which connects the medial epicondyle and olecranon to the flexor carpi ulnaris. That is known as the humeral arcade, and otherwise also it goes as a very long longitudinal course into that arcade, and that is the cubital tunnel, and then it goes inferiorly and enters the hand through at the level of or superficial to the carpal tunnel, and through a space between pisiform bone medially and the hook of hamate laterally, that is known as the Guyon's canal. And within the Guyon's canal, it divides into superficial sensory and deep muscular branches. So as for median nerve, it does not have any branch at the level of the arm. Immediately after it crosses the elbow, it gives two branches to a flexor carpi ulnaris as well as the medial two slips of flexor digitorum profundus. And then when it comes to the lower forearm, it gives off two cutaneous branches. You have first a palmar cutaneous branch which supplies the palmar aspect of the hand, not including the fingers, and a dorsal ulnar cutaneous nerve which supplies the dorsal part of the hand, excluding the fingers. And once it reaches the Guyon's canal, the deep muscular branch, which is a pure motor division, it gives off a branch to palmaris brevis, supplies all the hypothenar muscles as well as all the remaining intrinsic muscles of the hand, which are the palmar and dorsal interossei, the third and fourth lumbricals, the adductor pollicis, as well as an additional branch to the deep head of flexor pollicis brevis. The superficial sensory branch supplies the digital branches to the medial 1.5 fingers. So you can see that in the hand, the palm is supplied by the palmar cutaneous branch on the medial aspect. The dorsum is supplied by the dorsal cutaneous branch, including the fingers. The superficial branch of the ulnar nerve supplies the palmar aspect of the medial 1.5 fingers up to the tip of the fingers. So this is another case of a 32-year-old female who had rheumatoid arthritis and presented with numbness and weakness of right hand of 1 month duration, which was, she told it was in the medial 2 fingers, medial palm as well as forearm on that side, with inability to grip properly, especially she had difficulty with the little finger. She also had pain around the right elbow. It was obvious that the patient had active arthritis in the form of swollen elbows on both sides. On examination, she had weakness of the intrinsic muscles of hand, but no weakness of the proximal FCU or FTP. The intrinsic muscles of hand, the weakness was confined to the ulnar distribution. And sensory, the sensory loss was confined to the medial 1.5 fingers as well as the palm She also told that there is some impairment of the forearm sensation, but that was not consistent. So here we have the possibility of this being an ulnar neuropathy. And since there is involvement of the forearm, you also want to consider the possibility of either a plexus involvement, and there is also a possibility of a radical involvement. However, the motor distribution is strictly confined to the ulnar distribution, and examination of the forearm was not consistent, partly because the patient had severe pain in the entire elbow and arm region. So we just see how to approach this patient by seeing the ulnar, the different sites where ulnar nerve can be affected. So ulnar neuropathy at elbow is the second most common entrapment neuropathy. It is more commonly bilateral than unilateral when it occurs as a part of entrapment syndrome. The most common etiology is external compression, either due to repetitive injury or due to putting a cast or some other particular maneuvers. Can also be due to internal compression due to ganglia, tumors, or fibrous bands. They usually have both motor and sensory symptoms in the form of weakness of the ulnar innervated muscles and tingling and numbness of the medial 1.5 fingers. They usually also have tenderness at the level of elbow, along with nerve thickening and tenal sign at that level. So again, ulnar nerve also shows certain peculiar signs. There is wasting of the medial aspect of the thenar eminence with preservation of the lateral aspect. There is wasting of the FDI as well as guttering of the fingers, suggesting wasting of the interosseous and lumbricals. The Wartenberg sign is an early sign which is seen in ulnar neuropathy, which there is the little finger tends to be abducted, and the Froment sign can be seen by doing a card test. This is a normal response to keeping a card between the fisted hand as well and the extended thumb, and the examiner tries to pull it. When there is weakness of ulnar weakness, there is overactivity of the flexor. The adductor is weak and the FDI is weak, leading on to overactivity of the flexor pollicis to keep the card in place, and that is a Froment sign. So the typical picture of ulnar weakness is a claw hand, which is due to weakness of the interosseous and lumbricals, which is particularly on the medial aspect. So for the lateral, medial two fingers, there is hyperextension of the metacarpophalangeal joint and flexion at the level of the distal and proximal interphalangeal joints. The ulnar paradox means that if you have the ulnar lesion at the level of the wrist, the appearance of clawing is more severe compared to lesion of ulnar nerve at the level of elbow, and that is because the long flexors are spared in lesions of the wrist, so that they overact and produce more of clawing. But when the ulnar injury occurs above the level of elbow, you have involvement or weakness of the flexor distorum profundus, and the flexion of the distal interphalangeal joint is also weak, so that the clawing is not so prominent. That is known as the ulnar paradox. This is a partial claw hand due to ulnar weakness. If you have weakness of both median and ulnar, you can have a total claw hand, which is due to all interosseous and lumbricals being weak. In ortho terminology, there is also a sign which is known as intrinsic plus and intrinsic minus hand. So intrinsic minus hand means there is absence or weakness of the activity of the intrinsic muscles, which is same as a claw hand. On the other hand, intrinsic plus means intrinsic muscles are active or strong, and this usually occurs in case of spasticity or conditions like the swelling of the hand or facial tightening of the hand, which occurs following injury. So here you can see that there is flexion at the level of the MCP and extension at the level of the proximal and distal interphalangeal joint, and this is not due to a nerve weakness, but due to either an extreme spasticity or due to the facial or skeletal abnormalities. On the other hand, the intrinsic minus hand is due to ulnar weakness alone or ulnar plus median weakness alone. The etiology of ulnar neuropathy at elbow, the most common etiology right now is probably a mobile phone use or keeping the hand flexed and supporting in certain surfaces for prolonged periods of time. You can also get ulnar weakness with diabetes mellitus, hereditary neuropathy with liability to pressure palsy, as well as fractures, leprosy, and tumors and arthritis of the elbow region. It's good to know where exactly the nerve is getting impinged. So, as I mentioned, the nerve enters the forearm behind the groove in the middle epicondyle, which is known as the retrocondylar region. And then it enters aponeurosis and the tunnel within the FCU and aponeurosis, that is known as a cubital tunnel. Most of the compression occurs in the retrocondylar region, which is the most superficial location, whereas within the cubital tunnel there is less commonly do you get about 15-20% only have compression at that level. Keeping the elbow flexed is one of the strong risk factors for having repeated injury to that level, and that should be avoided in all patients who have suspicious symptoms of ulnar neuropathy at elbow. So in the patient where we had a suspicion of ulnar neuropathy versus plexopathy by radiculopathy, a conduction block was seen in the same ulnar nerve between the below and above elbow sides, showing that along with the conduction slowing across that region, very strongly suggesting that it is ulnar neuropathy at the level of elbow. The sensory studies, including the medial antebrachial cutaneous study, was normal, and this is possible if it is a pure demyelinating neuropathy, because sensory, if you don't do across that particular region, it may be normal when you study only the distal region. So by inching technique, we were able to make out that the focal demyelination was 1 centimeter proximal to the medial epicondyle, which is a common site for compression. And in this patient, it is probably related to arthritis that it occurred. EMG was also done in this patient, and the FCU as well as FDA showed a lot of denervation. There was no denervation from the other C8 innervated muscles or the paraspinal muscles. Ulnar neuropathy at the wrist is the second most common site. There is weakness of the intensive muscles of the hand, including the hypothenar muscles as well as the FCU and the intensive muscles of the hand and hypothenar muscles. But there is sparing of the FCU as well as the medial two the slips of the flexor digitorum profundus. The sensory, the palm and the dorsum is spared. Only the palmar aspect of the middle 1.5 fingers is affected. And depending upon where exactly the compression occurs, you may have a pure motor syndrome or a sensory motor syndrome, and very rarely you may have a pure sensory syndrome. In the Guyon's canal, it passes between the pisiform bone and the hook of the hamate bone. If the trunk of the nerve is affected, which is a little bit proximal to entering the Guyon's canal, you would get both a sensory and motor. Whereas if it occurs at this level, that is after it divides into the smaller superficial branch and a larger deep branch, if it occurs at the level where it is marked as 2, you will get weakness of hypothenar muscles as well as the other intrinsic muscles. At one point, it gives off the branch to the hypothenar muscles and then continues to supply the rest of the intrinsic muscles. And if the lesion occurs at that level, you may have only weakness of intrinsic muscles sparing the hypothenar muscles. And very rarely it is possible that there may be a lesion which involves only the sensory division. And the certain lifestyle factors are very important in leading on to ulnar neuropathy at risk, especially people who use hand grip repeatedly, like mechanics and carpenters. People who you do recreational activities such as long distance cycling, typists, all these people are prone to have a weakness of ulnar nerve at the level of the wrist. We come to radial nerve. It arises from the posterior cord of brachial plexus. This nerve has branches starting from the axilla till its ends. So in the axilla, it gives off the posterior cutaneous nerve of the arm, which supplies the posterior aspect of the arm. Then it moves down and enters or comes to in close contact with the spiral groove of the humerus. So at the time before entry into the spiral groove, it gives off 3 branches. One cutaneous branch which supplies the posterior aspect of the forearm. There's a posterior cutaneous nerve of forearm, and 2 muscular branches which supplies triceps and ancones. And then in the lower arm, after coursing through the spiral groove, it gives off branches to brachialis, which is also supplied to muscle cutaneous. It also supplies brachioradialis and extensor carpi radialis longus from above the elbow. At the elbow, it divides, or after the elbow, it divides into superficial and deep branches. The deep branch is known as the posterior androceus nerve, and that is the one which supplies the rest of the wrist and forearm extensors. So it supplies the extensor carpi radialis brevis, extensor carpi ulnaris, which is the wrist extensor. It supplies the extensor distorum, extensor dista minimi, extensor pollicis brevis, extensor indicis, which are extensors of fingers, and that is at the level of the MCP, and abductor pollicis longus, which abducts the first finger. The superficial branch is a sensory branch. Now, the most common cause of radial neuropathy is radial neuropathy at the spiral groove, which is also known as a Saturday night palsy. And this occurs because the radial nerve is acutely compressed at the level where it passes very close to the spiral groove. You can see that the nerve is in close opposition to the humerus at this level. And if the patient is inebriated, that is, has taken an excess of alcohol, or is unconscious, and the hand is resting on a hard surface such as the back of a chair, or the person himself lies on it, or a wet partner lies on the hand, that can lead to an acute compression. This is usually a fairly good prognosis of fractures of radial neuropathy at the level of at the level of the arm. You have both wrist drop and finger drop, with mild weakness of elbow flexion due to weakness of brachialis and brachioradialis. You can specifically test for brachioradialis and see that it is weak. Triceps is spared because the branch is given prior to the entry into the spiral groove. And sensory symptoms are in the, this is not accurate, in the 3 and autonomous sensory zone. Radial neuropathy can occur in certain specific conditions such as multifocal motor neuropathy, leprosy, lead poisoning, as well as there are 2 things which you should be differentiating in a case of patients who present with radial neuropathy. When you examine a patient with a wrist drop, you may feel that there is an ulnar weakness. You can check it in your own hand that when the hand is kept in flexion, it is not has to be stabilized and only be tested. Otherwise, you would end up thinking that it is not a mononeuropathy. There is we may believe that the lesion extends beyond the radial nerve. So you should always be looking out for that. Second one, how to differentiate from acute stroke. When patient wakes up with acute weakness of the hand in the morning, and which is purely motor, you may have a difficulty differentiating from stroke. And the main point to differentiate is that in a radial neuropathy, the extension of the distal interphalangeal joint will be spared because these are by the interossei and lumbricals. However, it will usually be weak in a case of a stroke patient who also has weakness of the finger extension, weakness at the MCP joint. Now, the posterior androceus nerve, or the motor branch of the radial nerve, the weakness produces a pure motor neuropathy. And similar to the anterior androceus nerve, most of the cases, the lesions, more than 80% cases, the lesion occurs in the radial nerve proximal to the elbow joint. But the next common cause is the region where this nerve passes through the supinator muscle, which is also known as the arcade of Fossey. The 2 signs which differentiated from the radial neuropathy is the presence of finger drop rather than wrist drop. So the wrist extension is maintained but finger extension is affected. Second is that when the patient tries to elevate the wrist, there is a radial deviation at the wrist, and that is because the extension of the wrist is predominantly by the extensor carpi radialis longus brevis and extensor carpi ulnaris. The ECR longus is applied from the lower arm, whereas ECU and ECR brevis is applied by the posterior interosseous nerve. So the ECR longus, which is one of the stronger muscles, is spared in a patient who has only pin palsy. And when this patient tries to extend, the wrist tends to deviate towards the radial side. So the finger drop and radial deviation of wrist on attempted extension will help in differentiating a pin palsy from a motor radial neuropathy. If you have pure involvement of the sensory of the median nerve, it is called as a chiralgia paresthetica, also known as Wartenberg syndrome. It is a compressive neuropathy usually, and it occurs when people use tight bangles or bracelets, or in prisoners who have been handcuffed. People who use repeated wrist movements may also tend to have a chiralgia paresthetica sensation, and the sensory loss and the anatomical stuff box is the most important sign. The provocative test to produce the similar paresthesia is a pronation of the forearm with ulnar flexion of the wrist, or by pinching and gripping the fingers, which would also aggravate the pain and paresthesia. Another nerve which is prone for entrapment is a suprascapular nerve. This nerve arises from the roots of the brachial plexus, and it is a C5 and C6 distribution. So when it enters to supply the muscle, it goes through two fibroosseous structures. Initially, it goes through suprascapular notch, and then it supplies the shoulder joint as well as the supraspinatus muscle. And it then goes lateral to the spine of the scapula through the spinoglenoid notch and supplies the infraspinatus muscle. So people who have hypertrophy of the muscle or repeated throwing activity can predispose to compression of the nerve at the suprascapular notch, and the weakness of supraspinatus, which is the first 15 degree of shoulder abduction, will be the presenting feature, along with weakness of infraspinatus, which is an external rotator. But if the weakness is confined or the compression occurs at the spinoglenoid notch, there will be only weakness of the infraspinatus without weakness of the supraspinatus. Again, this being an entrapment neuropathy, the provocative test is to either rotate the head to the opposite direction, or by adducting the scapula, the pain can be reproduced, and the spinoglenoid notch pain can be reproduced by external rotation of the shoulder. Now, wherever you have a nerve, you have a possibility that it can have a neuropathy. The other nerves which can be entrapped are the dorsal scapular nerve against the scalenus medius muscle and axillary nerve at the quadrilateral space in the axilla. But other nerves in the upper limbs, like long thoracic nerve, is also prone to mononeuropathy, especially as a part of Parsonage-Turner syndrome. I would mention a few words of a phrenic nerve. The phrenic nerve arises from the cervical plexus. When the weakness is unilateral, the patient may be asymptomatic or may only have exertional dyspnea. But when the weakness is bilateral, they present with supine dyspnea. The signs which you would look for unilateral weakness, you would look for latent sign. That is, when the patient breathes in, it is because of the parietal pleura remains very close to the diaphragm, and there is flattening of the lower intercostal space during inspiration, and that flattening is lost when there is unilateral weakness of diaphragm. When there is bilateral weakness of diaphragm, you would be looking for paradoxical breathing. That is, during inspiration, rather than the abdomen moving out, the abdomen would be moving in. Another test is a sniff test. That is, you can ask them to blow out a candle or do a sniff and try to see if the power is reduced or not. The medical causes are either iatrogenic or Parsonage-Turner syndrome, as well as with generalized neuropathies. But the most common causes are mediastinal lesions followed by neck lesions. We will come to the lower limbs. The sciatic nerve It is the largest nerve in the body which arises from the lumbosacral plexus with the root value from L4 to S2 and sometimes S3 as well. It lives through the greater sciatic foramen and under the piriformis muscle, and this is a very common site for compression, and then it goes below the gluteus maximus to reach the popliteal fossa. As was mentioned in the previous talk, the fibers to the common peroneal and the fibers which supply the tibial continue to remain separate throughout the course of the nerve. So in the thigh, it supplies a semitendinosus, semimembranosus, long head of biceps femoris and the hamstring part of the adductor magnus from the tibial portion, whereas the common peroneal portion supplies the short head of biceps femoris, and these are the only muscles which are supplied by the sciatic nerve alone. The rest of the muscles are all supplied by the branches, that is tibial and common peroneal separately. So sciatic neuropathy most often occurs at the level of hip. So a very common cause is hip replacement surgery or during pelvis structure for cancers. Intramuscular injections can also cause a sciatic injury, and usually severe pain can also occur because of that. Popliteal fossa is less commonly affected. So weakness, in addition to weakness of all the foot muscles, there is weakness of knee flexion, that is the hamstring muscles. The sensory loss is the entire region excepting the one which you see in violet, which is supplied by the saphenous nerve. So other than that, all the regions below the knee is affected and ankle jerk is lost. So as I mentioned, in this nerve, the common peroneal and tibial nerves travel separately, and the common peroneal division is highly susceptible to injury compared to tibial division. So even if you have a sciatic neuropathy, the patient may present only with weakness of the common peroneal division. And especially when injection is the cause, motor is more susceptible than sensory, you may only have a motor weakness. So certain terms which you need to understand. One is sciatica. So this is a very non-specific term. This refers to a pain which starts from the buttock and goes along the course of the sciatic nerve. And in about 85% cases, it is not due to the nerve involvement, it is due to lumbar radiculopathy. So this disease is the most common cause, followed by foraminal stenosis, spondylolisthesis, etc. But you can also have it due to the sciatic nerve involvement per se, or when the lumbosacral trunk is affected as an obstetric compression, tumors, etc. The test is very well known to us. You can, the straight leg raising test, when you have the reproduction of the pain between 30 and 70 degrees, that is the level at which the nerve is stretched. You have the same pain which is reproduced when the dorsiflexion of the ankle will increase the sensitivity of this test. So another common reason for a sciatic pain is a piriformis syndrome. The nerve is thought to be entrapped at the level of the greater sciatic notch, and the piriformis may be, or the tight piriformis may be one of the reasons why that occurs. So usually it is a pain syndrome without much of weakness or sensory loss. The pain is deep in the buttock and may or may not radiate in the lower limbs. It increases when the patient sits for a prolonged period of time or when walking or doing any activity. And if you deep digital palpation will reproduce the pain. So the provocative test which is most commonly used is a FAIR test. So if you flex the hip, adduct it and then internally rotate it, the pain is reproduced due to stretching of the muscle. Now we come to the most common lower limb mononeuropathy, that is a common peroneal neuropathy. So the common peroneal nerve, as soon as it arises at the level of popliteal fossa, it gives off two sensory nerves. One is a lateral cutaneous nerve of the calf and a very small lateral sural cutaneous nerve which joins with the medial sural cutaneous nerve of tibial and forms the sural nerve. It then winds around the head of the fibula, which is very important because that is a site where it is prone for compression, and enters the peroneus longus muscle where it divides into deep peroneal and superficial peroneal nerves. So the deep peroneal nerves is predominantly a motor nerve and supplies all the dorsiflexors of ankle and foot. That is a tibialis anterior, extensor hallucis longus, extensor digitorum longus, and extensor digitorum brevis. It also supplies a peroneus tertius, which is not a strong, which is an inverter but not a strong one. The cutaneous supply is peculiar, that is confined to the first interosseous space between the first and second toes. The superficial peroneal nerve is a dominant sensory nerve. It supplies the evertus, that is a peroneus longus and brevis, and then supplies the sensory along the lateral leg in the lower part, as well as the dorsum of foot, excepting the first space, which is supplied by the deep peroneal nerve. Now, the region which is shown in violet is supplied by the lateral cutaneous nerve of the leg, which comes from the common peroneal nerve, whereas the superficial peroneal nerve only supplies the lower part of it. So this is useful to differentiate a common peroneal versus a superficial peroneal neuropathy. Now, the common cause of peroneal squatting position or keeping the leg crossed for prolonged periods suitable to positioning within the ICU. Patient who's comatose or is staying for ICU for a long time or in a long period of anesthesia tends to have compression of the nerve at the level of the fibula head. Another one more thing, a ganglion at the level of the common peroneal origin or tumor is also a relatively common cause, and all patients with peroneal neuropathy should ideally get an ultrasound to see that there is no structural lesion in that region. So clinically, you have weakness of foot and ankle and toe dorsiflexion, eversion weakness, and mild weakness of inversion. Inversion is by tibialis anterior and tibialis posterior. Posterior is intact, but anterior is affected, so that there is mild weakness, but plantar flexion is spared. Angle jerk is also normal. The main differential diagnosis to be considered are sciatic neuropathy, where you have hamstring weakness as well. You can differentiate from an involvement of common peroneal division of sciatic nerve from common peroneal neuropathy, either by looking at the angle jerk is absent or by doing EMG where the lateral head of biceps femoris will be affected. Lumbosacral plexopathy, radiculopathy has been discussed in detail earlier and I won't be going through that again. The tibial nerve is basically at the level of popliteal fossa. It supplies the medial sural cutaneous nerve which joins with the branch from the peroneal and becomes a sural nerve. It then supplies the gastrocnemius and soleus and the tibialis posterior and the plantar flexors, flexor digitorum longus, flexor hallucis longus, and then enters a tarsal tunnel at the level of the malleolus and divides into medial plantar, lateral plantar, and medial calcaneal nerves. Now, the medial plantar supply is, you can remember by a thing that is almost equivalent to that of median nerve, and lateral plantar is almost equivalent to the ulnar nerve of the hand. So this supplies the medial two-thirds of the sole, cutaneous supply, and supplies the toe, abductor, flexor, and the first two lumbricals. But the lateral plantar nerve supplies the lateral one-third of the sole and also supplies the abductor, flexor of the little toe, adductor hallucis, and other intrinsic muscles, the interossei and the third and fourth lumbricals. So tibial nerve, the posteriorly, the sural supplies the posterior aspect of the leg as well as the lateralmost aspect of the foot as well as a little bit of the toe. The other three branches which arise from the tarsal tunnel, that is a medial plantar which supplies the front portion, two-thirds on medial aspect, one-third lateral aspect, and posteriorly you have the medial calcaneal branch which supplies the heel aspect. So tibial neuropathy is relatively uncommon, especially if it occurs, it usually occurs at the level of tarsal tunnel syndrome. When the etiology is more likely to be ischemic or vasculitic rather than a compression neuropathy if there is a tibial neuropathy. So weakness is mostly of plantar flexion of foot and inversion of foot and plantar flexion of toes as well as intrinsic muscles. Ankle jerk is lost and sensory loss is along the sural distribution as well as the sole and lateral border of foot. So tarsal tunnel syndrome is a relatively lax tunnel. It is not a very common phenomenon. Here, this is the most common site where the nerve tends to have a compression neuropathy. The tendons of tibialis posterior, FHL and FTL goes along with the median nerve, and it is within this tunnel that the tibial nerve divides into its branches. The patients usually have pain and burning paresthesias of the soles, along with tightness and cramping of foot. And this usually managed conservatively. One more syndrome which is very common is a Morton's metatarsalgia, which was previously known as Morton's neuroma. But it is not due to a neuroma. It occurs due to the fibrosis of the interdigital nerves, either between the second and third or the third and fourth. They usually have a very focal pain, which can be reproduced by pressing over that particular region of the pain. So as I mentioned, there are other nerves which can be entrapped in the lower limbs, particularly the lateral femoral cutaneous nerve across the inguinal ligament. Now, how do you approach the diagnosis for a mononeuropathy? You have to ask in the history specifically, are there repetitive behaviors, particularly their job or recreation activity? Any new habit, somebody who has started going to the gym and started doing 100 push-ups, a rapid loss in body weight, recently admitted in ICU, and a systemic illness like diabetes, all these should be particularly asked for in the history. You have to do provocative tests and palpate along the nerve to look for thickening or tenderness. And watch out for red flags which may suggest that it is not just an entrapment. For example, motor more affected or multiple nerves affected. All these are red flags to suggest that it may not be a mononeuropathy. I would just mention that nerve conduction, ultrasound of the nerve as well as magnetic resonance neurography are very important to confirm the diagnosis of focal neuropathy. I'll finish off in 5 minutes with what are multiple mononeuropathies. This is one term which used to confuse me a lot, particularly when the initial usage was mononeuritis multiplex. This is not an accurate terminology because it is not always due to inflammation. When you have multiple nerves which are affected or multiple single nerves which are affected, it is just called as mononeuropathy multiplex. So it is same as mononeuropathies except that more than one nerve is affected. And when that occurs, the chance it is more commonly due to a systemic disease than an entrapment neuropathy. The isolated nerves need not be together. They can be widely separated in different limbs. There may or may not be cranial nerve involvement. It is not a single disease like peripheral neuropathy. It is a condition which may have any cause of etiology. So one point which we need to understand with the mononeuropathy multiplex is that, see, you can see that here there is a median involvement, here there is an ulnar involvement, here there is a common peroneal neuropathy. When a patient presents like this, the diagnosis of mononeuropathy multiplex is very easy. But when they continue to progress, at one point, they may have a relatively symmetrical appearance or but this is not as a confluent or overlapping multifocal mononeuropathy. So this may look like a polyneuropathy unless we specifically ask the history to differentiate it. So what you want to know is that how was the onset and how asymmetric was the onset. So if we have the initial history being multifocal and asymmetric, we know that it is not a polyneuropathy, it is a mononeuropathy. Secondly, progression can occur in a stepwise pattern for a mononeuropathy multiplex, which means that today a patient may have an ulnar weakness which progresses for 1 month and then stops. So it stabilizes for about 6 months and then there is involvement of the opposite median involvement. So that kind of stepwise progression would indicate a mononeuropathy multiplex. Distribution is not length dependent, rather nerve dependent. So the upper limbs may be affected more than lower limbs. Proximal may be affected more than distal. There is no reason why it should follow any particular distribution. You may need to do a very focused clinical examination to differentiate polyradiculopathies and plexural neuropathies. And even when it is confluent, you may see that the distribution follows a nerve pattern. What I mean is that suppose a patient has weakness of hands and on examination you find that both ulnar, median and radial muscles are affected. You may find that ulnar is severely weak, median is mildly weak and radial is also mildly weak. That usually indicates that it is a multiple mononeuropathy and not a polyneuropathy. So etiology, the first three etiology would be vasculitis, that's the most common one. You have to also rule out that it is not an entrapment neuropathy, like diabetes may have and other polyneuropathies may predispose to entrapment neuropathies, and that can look like a mononeuropathy multiplex. HNPP is another condition where you can have multiple compression neuropathies. Diabetes, both due to entrapment as well as due to vasculitis, can produce neuropathies. I will just tell you a few points about the important differential diagnosis. So in vascular neuropathy, it is painful Usually sensory, motor and autonomic are affected. Lower limbs are more affected than upper limbs, and you tend to get the stepwise progression. It is important to ask whether there are any acute attacks, that is the onset to worst by less than 4 weeks. So all these points, lower limb involvement, painful and acute attacks, all these would suggest a vasculitic neuropathy. It can be primary vasculitis, secondary to connective tissue disease or infections or due to even malignancies, or non-systemic vasculitic neuropathy. In clinical evaluation, you want to ask if there is any evidence of constitutional symptoms, skin involvement, arthritis, or any other system involvement like lungs or renal disease or any other system involvement. The primary investigations would be autoantibodies and inflammatory markers, as well as secondary evaluation for infections and malignancy. It is usually an axonal neuropathy. For diabetes, it produces a lot of asymmetric neuropathies, like lumbosacral radical plexus neuropathy, brachial plexus neuropathy, truncal radiculopathies, and in addition, you may have entrapment neuropathies and peripheral neuropathies due to microvasculitis. And further confusing the picture, you may also have a diabetic polyneuropathy. So it is very essential in diabetes to examine and re-examine before labeling a patient as having an immunological neuropathy. Syndrome which is not very common is a sensory or migrating sensory neuritis, in which patient has multiple sensory painful patchy involvement, which worsens with movement of the limb, which is known as a stretch test. So here it is of unknown etiology and may or may not respond to steroid. The main symptom continues to be only sensory. There are 3 major demyelinating neuropathies which may present as mononeuropathy multiplex. MADSAM, which was discussed last time, which is a variant of CIDP, which responds to which has both sensory and motor involvement. Upper limbs, particularly ulnar and median, are more affected than other nerves. It is less responsive to immunotherapy than the classical CIDP. MMN-CB is a pure motor demyelinating phenotype. Again, upper limbs are more affected and there is a propensity for radial neuropathy to occur. HNPP should be differentiated from the other demyelinating neuropathies. So here they will usually give a history of a trivial compression which has precipitated a neuropathy, usually in younger people, adolescents itself it starts. And ulnar and peroneal are more commonly affected, followed by brachial plexus and radial nerve. Median, for some reason, is spared. Family history may be positive because it is a dominantly inherited disease. And what you should look for is specifically whether NCS shows abnormalities in the entrapment sites. And finally, the clinical approach is you decide whether it is sensory motor versus a limited forms. If it is motor, it could be MMN-CV, sensory could be Wattenberg. Axonal versus demyelinating. Demyelinating can occur with MMN-CV, MADSAM, HNPP and leprosy. See whether entrapment sites are more affected or not, which can be a polyneuropathy, rheumatoid arthritis, amyloidosis or HNPP. Evidence of systemic disease. Family history, you may get multiple pattern in HNPP, tangiers and neurofibromatosis. And distribution. You have to know that if it is a common, but single limb is showing multiple involvement, it is more likely to be a plexus rather than a multiple mononeuropathy. And proximal and distal involvement can occur, particularly when it is vasculitis. So I would summarize that this is a very common form of peripheral neuropathy, and the knowledge of anatomy is essential for localization, and knowledge of provocative maneuvers are also important to finalize that it is a mononeuropathy and not, it is an entrapment neuropathy and not due to an alternate etiology. Thank you.
Excellent lecture.
Yeah, thank you, Dr. Sruthi. It covered such a lot of points, a lot of topics in this 1 hour.
In good clinical clues.
Yeah. So in between, one point your audio was going off. At one particular point, you were showing a very important point of pseudo-ulnar.
Sorry, which one?
Yeah. When you were saying about the pin posterior interosseous with a pseudo-ulnar palsy, at that time your audio was not clear at that time. Some connectivity issue. Can you just repeat that what we were saying?
It's glad I can actually show it. I can show it actually rather than the slide. It's easier to show it in the hand.
Yeah.
So when you have a wrist probe, the interosseous cannot act properly because it is mechanically disadvantaged. So a patient who presents with radial palsy, you may feel that there is weakness of both the radial innervated muscles and the interosseous. And this usually erroneously leads to a diagnosis of a multiple mononeuropathy. or even or a stroke sometimes, because it is not in a single nerve distribution and occurs acutely. So what you would need to do is actually stabilize the hand and then do the clinical examination. So you put it on top of a table or on your on the patient's body itself, and then only you should do the examination for dorsal and palmar entroucher. You would also see that the hypothenar muscles are not weak, and the other nerves, the flexion of the third and fourth FDP is also not weak. So that is not affected by this one to the extent that entroucher are affected.
Yeah, we sometimes even people if you're not experienced, sometimes people totally miss the pin and report it as clinically as an ulnar nerve palsy, as a claw hand, even because of the particular position of the hand. So next, let's go to some.
I will also add that claw hand should require that there is hyperextension at this joint. That means a radial is spare. So there should be hyperextension here and flexion here. Yeah. So claw hand automatically means that radial is spare.
Yeah, true.
This extension.
So let's go to one of the questions. So what can be the causes of isolated extensor weakness at the index finger?
So I would say that wherever I have seen this, it is usually a form fruste or early involvement of the either pin or the radial nerve. So a patchy involvement for me usually suggests that it is there is a higher possibility of what you would say immunological cause such as MMNCB or something. Or sometimes I have even seen Hirayama's disease, where you can only have initially one or two fingers being weak, and then you would progress to have rest of the weakness. So that would suggest a patchy involvement, and it's not absolute, may suggest an immunological process. Anything to add, please, sir?
So let's
fascicular, it could be fascicular.
Yes, sir.
It could be fascicular involvement.
Yes, yes. It can be fascicular involvement also, but when it is usually acute, you don't find that kind of forefinger alone affected. Like a radial neuropathy at spiral group, you usually find all finger and all radial, the wrist drop, but finger drop, all of them.
So same thing which one study which you have shown, no? When where an anterior introitious nerve, most of the lesions are there in the upper part, not actually in the anterior. So that was quite interesting. It's surprising for me also. So to find out, do you think in those patients, if you do our EMG and NCS localization, will also show it to be at that region above?
No, it does not, because it is specifically only that fascicle is affected.
Okay.
So even in EMG, it will show only A and N1.
So ultimately, if you localize by EMG also, you may not pick it up unless neurographic. Yeah.
So in books, they have given that if you have subtle sensory, you may think that it is possibly at higher level. But the study was done in people who were absolutely diagnosed to have A. So I'm not sure how much overlap would be there.
Okay. So another question was, what is the mechanism of Wartenberg sign in ulnar neuropathy? ADM should also be affected in ulnar neuropathy. An exclamation mark. Is that? What is the mechanism of Wartenberg sign?
Right. So adductor dista minima is affected earliest. That is only reason for it, and there is eventually all of them will be affected. Both the palmar as well as the dorsal movements will be the abduction as well as adduction movements will be affected. It is just that it is the earliest one to be affected.
So can you explain the stroke versus radial palsy clinical clues?
The simplest clinical clue is that it is all confined to the radial distribution in case of a radial neuropathy. And in stroke, it will usually go beyond the distribution. Second point, which I had mentioned in my talk, was that in a radial neuropathy, you have weakness of the extension at MCP. You don't have weakness of extension at the proximal or distal interphalangeal joint. So particularly, if distal interphalangeal joint extension is spared, it is unlikely to be stroke.
Now, wrist drop can be the presentation of cortical infarct involving nerve area, and in that the distribution the what is called the topographic distribution of the finger. They can be finger drop, medial finger drop. And another important finding is dexterity. They will have some loss of dexterity. These can be. We have seen few cases of stroke presenting as finger drop and wrist drop.
Yes, sir. Thank you.
Yes, sir. And I have seen a patient. I mean, it's Dr. Prabhakar's patient. He had both MM and CB. He was on IVAG and recurrent. He developed a cortical stroke and developed a wrist drop. I mean, it's in the hand. It is very unusual. At that time, it was MRI proven stroke in the hand. So it was very unusual to, at that time, it was expected that it will be an MMNCB, comes with a relapse, you can take IVAG at that time. At that time he had. So never go by the presumed diagnosis that they had at that time. That was a good thing which we had. So any other question? Our questions are over. Anything else?